Picture this. A 10-year-old kid rolls into your emergency department presenting with a rapidly enlarging abdominal mass and a bowel obstruction. This isn't a wait-and-see kind of situation. This tumor is doubling in volume right before your eyes. Literally, it has a doubling time of just 24 hours, making it the fastest growing of any human tumor. You rush a biopsy, put the tissue under the microscope, and there it is. A striking, dark landscape peppered with pale, clear spaces. The classic Starry-Sky pattern. You are looking at a high-stakes clinical emergency, and getting this diagnosis right, immediately and accurately, is absolutely a matter of life and death.
That's right. We are talking about Burkitt lymphoma. Today, we're going to absolutely master the World Health Organization 5th edition diagnostic criteria. We'll decode the molecular pathogenesis, navigate those really tricky differential diagnoses, and break down the urgent management of one of the fastest growing human malignancies out there.
Here's how we're going to tackle this explainer. We'll start with the macro view, clinical presentation, and morphology, then zoom way down into the molecular biology, WHO subtypes, and that all-important immunophenotype and genetics. After that, we'll navigate the differential diagnoses to make sure we aren't getting fooled. And finally, zoom back out to tackle the clinical emergency, tumor lysis and treatment.
All right, let's jump straight into step 1, decoding the tissue architecture.
So let's talk about that Starry-Sky pattern. It looks incredibly striking, but what are you actually seeing biologically? Well, Burkitt has this insanely high proliferative rate, but along with that comes massive spontaneous apoptosis. Cells are dying just as fast as they're dividing. So that dark sky you're seeing, that is a confluent sheet of deeply basophilic lymphoma cells. And those pale stars, those are actually tingible body macrophages just gorging themselves on all that karyorectic apoptotic debris. But here's a massive diagnostic trap for you. Starry-Sky morphology is absolutely not specific to Burkitt lymphoma. You can easily see it in high-grade B-cell lymphoma, DLBCL, lymphoblastic lymphoma, and even just reactive germinal centers. So you can't just see a starry sky and call it Burkitt. No way.
Because of that, you've really got to look closely at the high-resolution histopathology. Under the scope, you're looking for complete architectural effacement. The cells themselves are medium-sized, think roughly the size of a histiocyte nucleus, and they're strikingly uniform or monomorphic. If you're seeing marked variation in cell size, actually, that should make you seriously second-guess Burkitt. You'll notice this deeply basophilic dark blue cytoplasm, which in tissue sections gives you those classic squared-off cell borders. If you're looking at an aspirate smear, keep an eye out for conspicuous cytoplasmic lipid vacuoles. And as you'd expect with a tumor growing this fast, almost every single high-power field is going to be packed with numerous mitotic figures and apoptotic bodies driving that rapid turnover.
Okay, moving on to categorizing the disease. Let's look at the molecular biology and WHO subtypes. Historically, we've organized Burkitt into 3 main epidemiologic buckets. Endemic, which is primarily seen in equatorial Africa, deeply tied to intense early life EBV and malaria exposure, and often presents as a jaw mass in young kids. Then there's sporadic, which happens worldwide and often presents as an abdominal or ileocecal mass in kids and young adults, just like our opening case. And finally, immunodeficiency-associated, which is largely linked to HIV or post-transplant scenarios. But, the WHO 5th edition is really shifting our perspective here. While those clinical buckets are definitely still useful, WHO 5 is heavily prioritizing the biological subtypes, specifically EBV positive versus EBV negative, because their core molecular pathways are actually quite different.
And that brings us to an incredibly high-yield concept for understanding EBV negative Burkitt biology. These tumors rely heavily on specific cellular mutations to survive the massive stress of all that proliferation. Let's walk through the ID3 TCF3 CCND3 pathway. Step 1, you get a loss-of-function mutation that completely inactivates ID3. Now, normally, ID3 acts like the brakes for TCF3. So step 2, without ID3, TCF3 transcription factor activity just goes wild, unrestricted. Step 3, this rampant TCF3 drives tonic B-cell receptor and PI3K signaling and dials way up on CCND3 expression. Ultimately, this stabilizes cyclin D3, aggressively pushing the cell from G1 to S phase. This whole pathway is essentially a molecular escape hatch, allowing the lymphoma cells to survive and multiply despite crazy levels of MYC-induced genomic stress.
Let's dig even deeper now. Time to look at the immunophenotype and genetics, the true molecular signature of the disease. When you stain for Ki-67, the proliferation index, you want to see a number greater than 95%, ideally approaching 100%. The tissue should literally look like a solid brown sheet. And here is a massive exam pearl for you.
If you're seeing a Ki-67 of around 70 or 80%, you really need to step back and rethink classic Burkitt. But don't fall for the reverse trap either. A near 100% Ki-67 all by itself does not establish the diagnosis, because some DLBCLs can be incredibly proliferative too.
Because of that, you absolutely need the complete immunophenotype. Now, Burkitt arises from germinal center B cells, so it essentially mimics dark zone central blasts. You're going to see strong expression of mature B cell markers, CD19, CD20, CD22, CD79A, and PAX5. Crucially, you need those germinal center markers. It should be strong CD10 positive and BCL6 positive. Another vital clue to look for is strong surface immunoglobulin, usually IgM with light chain restriction. That's key because it confirms mature B-cell differentiation, which helps you definitively rule out B lymphoblastic leukemia. Finally, BCL2 should be either totally negative or very weak, and precursor markers like TDT and CD34, they absolutely must be negative.
To really lock this diagnosis in, we turn to the genetics. So normal dark zone cells don't just express MYC continuously. Burkitt lymphoma acquires constitutive MYC activation via a chromosomal translocation. In about 80% of cases, this is your classic T814 translocation. This moves the MYC gene on chromosome 8 right next to the immunoglobulin heavy chain locus on chromosome 14. In less common cases, MYC might pair up with the light chains, kappa or lambda. The end result is disastrous. MYC gets placed directly under the control of a hyperactive immunoglobulin enhancer, which basically hits the gas pedal on ribosome biogenesis, metabolism, and nonstop cell cycle progression.
All right, we've got our suspected profile. But how do we make sure we aren't being fooled? Let's talk about excluding the mimics.
You really have to confidently separate Burkitt from its major high-grade lookalikes, and comparing them side by side builds serious diagnostic confidence. Keep a close eye on those high-grade B-cell lymphomas, the ones we used to call double-hit lymphomas. Here's a massive do-not-miss pearl for your practice. If your BCL2 protein expression is strong and diffuse, or if your FISH panel reveals a BCL2 rearrangement, that strongly argues against classic Burkitt. Remember, true Burkitt should have negative or very weak BCL2 and absolutely zero BCL2 rearrangement.
But what happens if you have a tumor with perfect Burkitt morphology, 100% Ki-67, it's CD10 positive, but your FISH comes back with no MYC rearrangement? Well, heed this strict rule from the diagnostic experts. Do not call MYC-negative Burkitt lymphoma until HGBL with 11q aberration and cryptic MYC alteration are excluded. High-grade B-cell lymphoma with 11q aberration is a near-perfect morphological mimic of Burkitt, but it lacks the MYC rearrangement. Instead, it has a very specific pattern of gains and losses on chromosome 11q. You absolutely have to test for it before even considering calling something MYC-negative Burkitt.
Okay, the diagnosis is confirmed. But now we are facing a massive clinical emergency, tumor lysis and treatment urgency.
Because of how fast this tumor grows, it carries one of the highest risks for tumor lysis syndrome of any human malignancy out there. These cells are dying rapidly, spilling huge amounts of potassium, phosphate, and uric acid straight into the bloodstream. This can quickly lead to acute kidney injury and fatal arrhythmias. For prevention, aggressive hydration is key, along with uric acid-lowering agents. You got two main options here. Allopurinol prevents the formation of new uric acid, but honestly, it doesn't do a thing to rapidly clear the massive stores already circulating. Rasburicase, on the other hand, actively converts existing uric acid into a highly soluble metabolite that the kidneys can easily flush out. It's definitely preferred for high-risk patients. But watch out for this clinical trap. Rasburicase can cause severe hemolysis and methemoglobinemia in patients with G6PD deficiency, so be incredibly careful there.
Once you have tumor lysis managed, you need to initiate treatment immediately. And let me state this emphatically. Standard R-CHOP is completely inadequate for Burkitt lymphoma. Why? Because it's given every 3 weeks. That is way too slow for Burkitt's tumor kinetics. The tumor will literally just grow right back between your cycles. Instead, you need intensive, short-duration multi-agent therapy. For adults, we're talking dose-adjusted Epoch-R, Arcodex-M alternating with RIV-AC, or Hyper-CVAD plus rituximab. For kids, risk-adapted regimens like LMB or BFM protocols are standard. When delivered promptly, these regimens yield fantastic cure rates.
And you simply cannot ignore the central nervous system. Burkitt has a really high propensity to invade the leptomeninges and cranial nerves. Watch for clinical features like severe headaches, cranial nerve palsies, diplopia, or jaw numbness.
You have to evaluate the CSF using both cytology and flow cytometry. But here's the absolute bottom line for management. CNS-directed therapy is mandatory. Whether you use intrathecal methotrexate, cytarabine, or systemic high-dose agents, you must provide CNS prophylaxis even if the baseline CSF is completely negative. Skipping this is just asking for a fatal CNS relapse.
Let's wrap this explainer up with an ultimate diagnostic checklist for your exams and daily practice. When you see a clinical picture of incredibly rapid growth paired with a germinal center B-cell phenotype, a Ki-67 essentially at 100%, that monomorphic medium-sized cell morphology, and an IG MYC rearrangement, think Burkitt lymphoma. Be rigorous about excluding those high-grade mimics, watch out for the BCL2 trap, and get ahead of tumor lysis right away. Yes, it's an incredibly aggressive disease, but with sharp diagnostics and intense chemotherapy, it's highly curable.